Okay, I hope I'm live. Good afternoon, everyone. Thank you for coming or joining us virtually for the Center on Aging and Health Scientific Seminar Series. This is continuation of our series that we've been going hybrid all year, but this is the first meeting, I believe, where at least some of us are going maskless and hoping that we're not violating any rules. So thank you all for coming and being here. Just want to make a few announcements before we turn it over to today's speaker. As I think most everyone knows, this seminar series is generously sponsored by the Matthew Tabak Memorial Lecture Fund through the Division of Geriatric Medicine and Gerontology, and we also enjoy strong and regular sponsorship from the Older Americans Independence Center and the Epidemiology and Biostatistics Aging Training Program. And want to go ahead and pre-announce that 1 month from today, or on Monday, May 2nd, we have our next speaker in the seminar series lined up. That speaker will be Todd Brown, who's a professor of medicine and epidemiology, and he's going to talk on frailty in people living with HIV and accelerated phenotype. So please put that on your calendars for 4 weeks from today at 3:30, and Todd Brown will be speaking to us here at that time. Today, we're fortunate to have with us on relatively short notice a colleague of mine from the University of Maryland, Baltimore, named John Cagle. John is an associate professor in the School of Social Work at the University of Maryland and has built quite a record of expertise, especially in end-of-life care and palliative care. John got his bachelor's degree at Mary Washington College in Fredericksburg, Virginia, where he majored in psychology and English. He then went on to Virginia Commonwealth University, where he earned an MSW and then later a PhD in social work. After that, he completed 2 postdocs, one at the University of North Carolina Institute on Aging. And yes, he will be cheering at least slightly for the Tar Heels tonight against my Kansas Jayhawks. Then he went on and did a second postdoc at the University of California, San Francisco. After that, he took a faculty position at the University of Maryland, Baltimore, first as an assistant professor and now an associate professor in their School of Social Work. John's CV is very impressive to look at. He's won a number of awards for his teaching and his research and his public service, as a whole boatload of publications and book chapters that he's authored, and has really established himself as, I think, an expert in palliative care and social work contributions to end-of-life planning. And indeed, that's how I know him, is he's a co-investigator on one of Jennifer Wolf's grants that we're both working on as co-investigators on her team. So I will, with that, turn it over to John. The title of his talk is Improving Care at the End of Life During Concurrent Public Health Crises. Welcome, John.
Thank you very much, David. Hello, everyone, live in the room and joining us online. I'm excited about today's talk. It's been a while since I've been at a lecture podium with a live audience. So this feels familiar, but it's been removed from me for a while. Today, what I'd like to do, I apologize in advance. Are there some technical issues?
Getting your head in the frame.
That's what I get for being so tall. Story of my life, being cut off at the forehead for most of my pictures. All right, I'm just gonna forge a path on through. So I want to apologize in advance. Today's presentation is a little scattered, but scattered by design. After talking with David about what would be best to deliver, we thought maybe giving you a sense of, well, who I am, where I came from, my trajectory, some of my past projects centering on informing end-of-life care and best practices there, as well as the focus of this talk, which is thinking about how the opioid crisis and the pandemic have impacted end-of-life care with 2 projects. One that is in progress, a clinical trial called Uplift, and the other a recent past project that was focusing on the opioid crisis, how those 2 concurrent public health crises have influenced care at the end of life. And then at the end, talk about some lessons learned. So thank you for joining me on this journey. I do have the National Survey of Hospices highlighted, and that's because the bulk of the research information and data presented today will come from that, and that's because that study, well, we have interesting data to report, and a lot of the other projects are still underway. So a little bit about me. Thank you, David, for that nice introduction. One thing that I think is critical to my trajectory is the fact that I was a hospice social worker for 10 years. And so I have interacted with thousands of dying patients and their families. And that, I feel, has provided me with a lot of rich real world research questions that have parlayed to funded grants. And sure, you want to be able to justify your work with the previous literature, but when you're looking face to face with families that are dealing with economic crises in the middle of dealing with a terminal diagnosis, or wanting to be intimate with their partner and dealing with a cancer diagnosis, but they're in a bed made for one person, and a physician is reluctant to prescribe Viagra because there are major risks involved. So that clinical experience, I think, has been incredibly valuable for informing my work. My PhD focused on caregiver geography, looking at different types of proximity to a patient and the support needs for those that are long-distance caregivers, caregivers living at a loved one, or caregivers that live nearby. And happy to talk about that, although it's not the focus of my talk today. And like David mentioned, I did do 2 postdocs. I would like to acknowledge my mentors. I do stand on the shoulders of giants. Dr. Cheryl Zimmerman at UNC, and Alex Smith and Ken Konvensky at the Division of Geriatrics at UCSF. So my guiding light, my personal mission, has been to improve the care and support that we provide to dying individuals and their families. And the focus of my research largely has been on supporting family caregivers. If you think about who is out there really providing the day-to-day hands-on care for people who are dying, it's mainly family caregivers, folks who don't have a whole lot of medical training or skills related to treating serious progressive illness. And so I've done a lot to look at how we can better support and educate those family caregivers. And the idea is that if they get supported, then the patients at the end of the day will get better care. Improving pain management, that's kind of a central focus for hospice and palliative care. While it is a central focus, there's a lot of discomfort with treating because the biggest treatments, most utilized treatments in hospice and palliative care are narcotic-based treatments. There's a lot of stigma that comes along with employing those treatments in practice. And we are perhaps seeing more of those concerns with the rise of the opioid crisis. I've also worked on enhancing quality of care, looking at quality indicators, quality metrics to track how we're doing, particularly in hospice, and then ways of improving access to hospice and palliative care. Here are just three studies that I'd like to ever so quickly highlight. The first is Empower. This was a clinical trial with 4 hospices in a group randomized controlled approach. And the idea was to address barriers to management in hospice. As I mentioned, people have many concerns, worries about administering pain medications. Sometimes patients themselves are reluctant to even admit when they're in pain. And so kind of overcoming maybe that stoicism or the concern about being perceived as a drug addict. Those kinds of stigmatized beliefs we addressed with the Empower approach to overcome them. So hopefully we would see improved outcomes. And we were fortunate enough to see that patients in our intervention group on average had a 1.5 lower level of pain at 2 weeks post-intervention compared to our patients in our control group. So that was very exciting, and that has translated into quite a few other studies. Next, I'd like to talk about estimating the underutilization of hospice nationally. I was just talking with David about how the HRS data set is housed here in the cold room. And we use the HRS data set to estimate hospice use and the underutilization of hospice. And that study published in JAGS found that roughly 1 million patients die every year. And these are individuals who would qualify for hospice and likely want hospice. Roughly 1 million individuals, we estimate, die without hospice services. And these are mainly non-cancer individuals. And so our focus in future work is to look at how we can better identify non-cancer patients who have progressive illness to at least inform them about the benefits of hospice. Hospice isn't for everyone, but if they do qualify for it, they're eligible for it, they should, in my opinion, at least be informed about that available benefit. And this was a project done with Catherine Ornstein. David, I know you've worked with her before, quite an amazing colleague. And I also want to talk about another study screening for intimacy and sexuality concerns in palliative care. This was through some folks at MedStar, mainly Ann Kellerman and her group. And we found that 70% of patients who are in the last year of life reported that their illness had negatively impacted their intimacy, their relationships, their sexuality, and yet providers were not having these kinds of conversations, even though those individuals wanted to talk about these issues. So I'm just kind of teasing these, throwing these out, because I want to give you a sense of, I have this clear vein of research, but it has taken me in several different tangents, and I'd be willing to talk about some of those. I want to talk about 2 works in progress, one with Dr. Jennifer Wolf here at Hopkins. I am co-investigator with her, and David is also a co-investigator on this project. It's a study to improve advanced care planning communication among primary care patients with cognitive impairment in their families. And this is a 2-group single-blind randomized trial. Wanted to mention that. I thought I would be remiss if I didn't. Okay, so this is one of these studies that I am currently engaged in as PI, and a study that has been greatly impacted by the presence of COVID. So this study is a large multi-state trial to improve the care and quality of life for nursing home residents with dementia. My co-PI, Dr. Kathleen Unroe at Indiana, is working on the Indiana side of things. This is a phase 3 clinical trial funded by NIA. Just a little more about this study. We are in year number 2 of Uplift. It's a 5-year study. It's a step wedge randomized controlled trial. And we are randomizing the rollout of Uplift at the nursing home level. But the data analysis is occurring at the resident level. We are recruiting 16 nursing homes. We just finished baseline data collection in 3 nursing homes, and we are about to move into data collection with 5 nursing homes across both Indiana and Maryland. And we're looking at an average of 40 residents with cognitive impairment, not necessarily a diagnosis of dementia, but with cognitive impairment. And we are also recruiting staff members and family members because we need knowledgeable informants to give us outcome information about the quality of life and quality of care for these residents. There are some serious limitations with that. In most studies, you want to get information directly from the people that are receiving the care themselves. But when it comes to persons living with dementia, that's often not the case. And so we have to resort to proxy or surrogate report. This is just a table illustrating our stepped wedge design. You can see that we're right at the end of year 2, so right here. And we were hoping to have 4 facilities in the first year, but 1 facility dropped out. And so that first wave group just had 3 facilities in it, unfortunately. And that 1 facility that dropped out cited major COVID outbreak coupled with staffing shortages. And we're seeing major staffing shortages across all of our nursing homes, and that has complicated recruitment of these facilities quite a bit. And the fact that nursing homes are short-staffed or that there's a lot of turnover in long-term care isn't necessarily an unusual thing, but it appears that things have gotten quite a bit worse during the pandemic. And so there's a good chance that the pandemic is to blame for at least exacerbating this concern already. As I mentioned, we're wrapping up year 2 for Uplift. In fact, I think our new cycle started on Friday, so last Friday. So just finished year 2, starting year 3. And so far we do have baseline data on 138 residents in 3 facilities. Our outcomes, we're looking at proxy reported outcomes that have been validated in nursing home settings and that are appropriate for individuals who have dementia or dementia-like symptoms. And so we're using the end-of-life dementia comfort assessment and dying scale, the EOLD CAD, as well as 2 single-item quality of life measures. These aren't the only measures, but these are the 2 primary measures. Well, the 2 primary foci for our study. We're just about to launch baseline data collection in 5 facilities. Starting this month. Got a bunch of emails to set up times to meet with these folks. All right, so that was one study that has been impacted by COVID. And here is the study I'd like to spend most of my time on. This is a national survey of hospices to describe the impact of the opioid crisis. For those of you that aren't familiar with hospice, when I'm speaking with an audience such as this, I often assume that you're very familiar with hospice, but I don't want to necessarily make that assumption. Sometimes I use the pulpit to educate people about what hospice is and is not. So hospice is an interdisciplinary form of care that focuses on often symptom management to improve the quality of life for patients and their families. Quite often that turns into support for the family so that the patient gets better care. And this is important, typically hospice care occurs in the home. So not in an institutional setting, not in the hospital, not in an inpatient setting. It can occur in a hospital or inpatient setting or long-term care, but typically, most often, it is provided at home in a private residence. So the hospice team comes out to you in your house and provides care and support there. So they're a mobile team that comes to you. That's important when thinking about the hospice environment, so to speak, because it does typically include home care. This was my sabbatical research. This is what I did take a trip to the Grand Canyon, but after that, I put my nose to the grindstone, and this was a bit of a shoestring research project. This was all done for under $100,000. So it was, I didn't get any direct support out of this for my effort. I volunteered all my time. Of course, I was on sabbatical, so I could do that. But this was a very inexpensive project, all things considered. So a little bit about the background and rationale. Why did I pursue this research project? Well, we don't have a lot of information about how hospices are dealing with the opioid crisis, how controlled meds are being monitored, how at-risk families are being identified or cared for. And when we say at-risk, patients or family members who may have a history of substance use. The prevalence of diversion, and when I say diversion, that means when medications that are prescribed for a patient are taken from them and either used illicitly by someone other than the prescribed individual who they were prescribed for, or perhaps sold on the street illegally. We didn't know a lot about medications shortages. We heard a lot of this anecdotal evidence that hospices weren't able to obtain medications that they wanted to use for pain and symptom management. And so we wanted to articulate that, provide some evidence there. And also, there's a lot of anecdotal evidence about medication disposal practices, but nothing definitive. And so we were hoping to describe that. And going back to my personal mission, why do I care about this? Well, if pain medications aren't getting to the patients, if they're being diverted and they end up going somewhere else, then those dying individuals likely aren't getting good care and are suffering. So that's why I care about it. Plus, if there's something that I could do to help stem the opioid crisis, you know, I'm all about working that angle as well. But really, my love is for these dying patients and their families. So this project had 3 aims. The first aim was to provide national estimates of screening for substance use disorder, national estimates of opioids being left in the home after a death, and estimates of drug diversion, both suspected and confirmed. Aim 2 is qualitative. And so we were looking to describe and summarize promising practices for prevention, strategies for detecting and responding when drug diversion does occur, and looking for how to screen, modify practices for patients and families who are at risk for substance misuse or addiction. And the last aim, I guess I don't have it here. Aim 3 was do a Delphi study of experts to come up with recommendations for dealing with these opioid related issues, how to address diversion and potential misuse in hospices. And I'll talk a little bit about that. I apologize for not putting names for you here. So we had a big group of funders and folks who supported this project. And so these are the people who contributed. These are the folks who actually did all the hard work of collecting the data. This is my data collection team. They're the ones who called these hospices and conducted tons and tons of over the phone interviews. The project manager, Oren Ware, there is, he's a newly minted PhD and is now at UNC. So just got an appointment there. All right. So how do we go about doing this national survey? First, we randomly selected 600 agencies from the 2015 Medicare Hospice Provider of Service file. At the time that I was doing this study in 2018, that was the most recently available provider of service file I could put my hands on. And so that's why we use that. We proportionately stratified by both state and profit status. And when we were calling the agencies that were picked up in our sample, we were looking for representatives who were knowledgeable about clinical practices and agency policies and employed there at least 6 months because we wanted knowledgeable informants who could talk about practices at their hospital. As I mentioned, the survey was primarily done by phone, although we did offer a self-administered online option. We used Qualtrics. We employed the tailored design method. Those of you that are familiar with Don Dillman, his work, is a bit of a guru when it comes to survey methodology. We also used the universal design approach, which basically recommends aligning your self-administered online option with your phone survey so that you can combine them. So our measures were consistent across formats with very few changes. Data collection occurred for 15 weeks, June to September of 2018. And we were considered IRB exempt since we were collecting agency level information. And if any patient level information was divulged during our conversations, they were, of course, masked. Unfortunately, we weren't able to include Puerto Rico or any US territories. Originally, we tried to do that, but then when we called a few of the Puerto Rico based hospices, they could not complete our measures in English, at least fully complete our measures. And so we decided that it would make sense to exclude them, unfortunately. So the survey measures themselves inquired about end-of-life care within the context of opioid crisis, including medication shortages, screening practices, diversion and missing medications, and medication disposal. And we did our best to vet these items because we did create them. We didn't get them from anyone else. So we used cognitive interviews to meticulously go through each question and make sure that they were being interpreted appropriately and they were worded well. And then we pilot tested it before we went live. We did that with 12 agencies that were outside of our original sample of 600. The interviews were recorded with permission, and then we checked those just to make sure that we were documenting. All right, so the results for this, we ended up with 371 hospices who participated in the survey, who gave complete responses. And that's a response rate of 62%. I threw a party for my team after we did that because you don't see a whole lot of response rates that high anymore. I will say that one thing that we greatly benefited from was we went to the top 20 hospice care providers in advance and got approval, corporate approval from those hospices prior to reaching out to any of these agencies. And I do think that going to those leading providers and getting permission ahead of time really helped us with obtaining a strong response rate here. So 63% of our surveys were phone facilitated. And let's see, most of the folks were clinical supervisors or director of patient services. We also had administrators or managers. 18% were executives, so presidents, CEOs, or directors of the hospice. And they were relatively seasoned respondents with an average tenure at the agency of about 8 years. This is a breakdown of our sample characteristics. When putting this next to all Medicare certified hospice agencies in the country, we did notice some discrepancies. So we ended up weighting our data to account for those differences. Just to be transparent, we found that smaller agencies were less likely to participate. That's possibly because we went to those leading top 20 organizations in advance. And we ended up with disproportionately fewer for-profit agencies in our sample. So we weighted the sample accordingly. And just so you know, the data here are presented are weighted, although the sample weights did not substantively change any of the reported percentages. Yes.
I'm just curious why there were so few weights. Is that the way the sampling set up, or was it disproportionate refusal in the Northeast?
This reflects the generally the geographic distribution that we see nationally.
Wow.
Yeah. So this is generally reflective of what we see nationally. So I don't have a good explanation for why it's that way. It is possible that agencies in the Northeast are larger, and so that there are fewer, but still taking care of more people. That's something that I could answer empirically if you're interested in pursuing that further. As I mentioned earlier, the majority of hospice care is provided at home. All 100% of agencies who provided complete data in our sample indicated that they at least provide some home care. 36% of responding agencies reported that diversion prevention efforts create obstacles for pain management. And so diversion prevention efforts could be prescribing limits, could be tighter oversight on prescribers, greater use of PDMPs, which are the pharmacy monitoring systems that look at opioid prescribing within a given state. So those diversion prevention efforts might be creating challenges for hospice providers as they're trying to provide relief and manage symptoms. 45% reported drug shortages over the past year. And then we looked at which specific drugs were in short supply. And you could see here that morphine and hydromorphone were the two top leading drugs in short supply, but that quite a few controlled substances were in short supply. So when thinking about screening, identifying families who may have a history of substance use disorder, roughly 3/4 of hospices screened patients for a history of substance use disorder. 43% screened the informal caregivers, so the family members who are caring for the patient at home were screened. And 24% of hospices reported that they discharged a patient alive because of diversion-related concerns within the past month. And so maybe medications were going missing and hospices did not want to be liable for facilitating diversion. And so they would discharge patients from their care. But then my concern is always, what happens to these dying patients? So in estimating diversion, we found that 67% of agencies reported that they had 0 cases of confirmed diversion within the past 90 days. We asked about the past 90 days because we wanted a discrete, memorable time frame that people could reasonably estimate when diversion had occurred. And on average, 0.85 reported cases of confirmed diversion had occurred within the past 90 days. And 64% reported medications never or rarely go missing. So it occurs, but it is rather infrequent. When diversion and missing medications do confirm or are confirmed, for confirmed cases, who is doing the diversion? And here you can see a breakdown of who was responsible for diverting the medication. In some cases, it was the patient. You can see there it was in 33% of cases, the patient was diverting the medications. There were reports in our qualitative data of patients getting medication from the hospice and then turning around and selling the medication. And that could end up being some kind of indicator for the economic troubles that some of our patients are dealing with. Yeah. Yes, I've got a little note down here that says percentages may not add up to 100% due to multiple responses. So excellent catch. Yeah, so multiple people could be doing the diverting, and so it could be both the patient and the primary family caregiver, for example. So some qualitative information to add context to this. This is just one example of diversion. A respondent reported that the nurse had counted medication on suspected diversion. When the nurse arrived, the granddaughter started grabbing her keys and scurrying to leave. As she was leaving, the medication in the prescription bottle fell out of her purse. And so that was one example of a confirmed case of diversion. So here I present estimates of both confirmed and suspected diversion. Let me just walk you through this table a little bit. At the top, we've got our full sample of 371 agencies. Below that, we have the number of patients that those agencies were collectively caring for at the time of data collection. So they were caring for more than 40,000 patients. And then we broke it, stratified our findings by agency size. So we've got small agencies providing care to less than 25 patients, I believe. Medium size hospices that are 25 to 150, and then large hospices that are providing care to over 150 patients. And one thing I would like to point out is the heightened higher number of reported confirmed cases for these small hospices. The rate per 1,000 for small hospices of confirmed diversion was 18.9, which is substantially higher than what we see for the medium and large hospices. This is one thing I haven't been able to fully make sense of. I think it's possible that smaller agencies are perhaps more in tune with what's going on with their caseloads, and so they're able to see when these things are happening. So maybe there's greater attention when the agency is smaller. It's also possible that for the larger agencies, the respondent simply isn't aware of all the different cases of diversion that are going on, and so it doesn't end up getting reported. So that's a possible limitation there, but that was one curious finding that came out of our estimated rates of confirmed and suspected diversion. You can see that the suspected rates are also substantially higher. Of course.
So what's considered small, medium, large? I'm sorry. Oh, is that
This is 1 to 25 patients on a caseload. So an active patient census at the time of data collection. And I think you can see that the cut point between medium and large is 100, and I think I said 150.
So that's the caseload for what?
That is the caseload that the hospice agency is providing care to at the time of data collection.
I don't want to get too far sidetracked on this, but I work with staff at Austin. I became aware that a lot of people only get hospice for a few days. They're right on stage cancer, and they only get it for 3 or 4 days when they pass. So is that truly related to that part of the caseload that really comment about sort of length of
So
stay?
that's an excellent question. This is completely cross-sectional. So we were taking that snapshot at the time of data collection. How many patients do you have on your census right now? And so because it's not longitudinal, we weren't looking at how things played out over time. So we don't have any information on, is there more diversion for short stay patients rather than long stay patients? I would imagine because there's simply more opportunity for a long stay patient that there's a greater chance of diversion or misuse, but I don't know, because we didn't look at that. Other questions? All right. So drug disposal, we were also very interested in whether and how drugs were being disposed of after a death. So these are unused medications that are still in the home at the time of death. And 52% of reported of employees, 52% of agencies reported that their employees were not allowed to dispose of medications after a home death. So by policy, either state policy or agency policy or beliefs about federal policy, they said that they could not dispose of the medications. After a home death, they reported that unused medications were left in the home and estimated 33% of the time. And you might be looking at the 52 and the 33% and saying, oh, well, it looks like somehow the medications are getting disposed of. It's quite possible that the employees are walking the families through the disposal process. So the employees themselves can't do it, but they can request or inform the families on how to do it. And so here are kind of the discussion points, the takeaway points from this national survey. Minority of hospices screen family members for risk. However, they are the most common diverters when you think about who was doing the confirmed diversion. Nearly half of hospices reported medication shortages. So it seems like the opioid crisis, coupled with some other supply line issues, and I'm saying other supply line issues. Hurricane Maria, which hit Puerto Rico, negatively impacted access to liquid forms of morphine for the majority of the country. And so that's not necessarily related to the opioid epidemic, but that's one of those external circumstances which is contributing to this access problem. So when adjusting for agency size, smaller hospices have much higher rates of diversion, at least based on what we found. The lack of opioid disposal in a third of homes is a major concern. And the limitations for the study, of course, this is self-reported based on the agency respondents' knowledge. A lot of these issues are, of course, hidden and stigmatized phenomena. So, you know, getting good, accurate information about when diversion or misuse is occurring is a major challenge. And we didn't get any input from patients and families, so we don't have much on their perspectives related to these issues. This is kind of on my radar for something I'm looking to address next. Based on what we found in this survey, we think that opioid medications are being left in over 170,000 homes in the US after a hospice death. And so I am hoping to, I've already got a strong draft of a grant ready to go to NIH to do a simple intervention to follow up with these families and offer them one more visit from the hospice nurse to help facilitate medication disposal. But we're also looking at ways to stem the confirmed cases of drug diversion and other opportunities for misuse by employing our recommendations. And like I said, we did a modified Delphi study to produce recommendations. I've got really small picture of the document there. We came up with 15 recommendations for preventing misuse and diversion in hospices. Here are some of the publications that came out of that. You can see that Warren did a nice job of padding his CV with some good publications there. And okay, so bringing it all back, thinking about Uplift, thinking about this opioid survey completed by hospices, what are some of the big takeaways about providing end-of-life care in the context of these two major health crises? At least when it comes to hospices and the opioid epidemic, even though it's infrequent, medication diversion is occurring in hospices. The home environment is the preferred place for end-of-life care. When you look at surveys and you ask people open-endedly where they would like to be cared for in their dying days, most people want to be at home with familiar faces and familiar surroundings. The second most common response to that is on some deserted islands or some tropical island somewhere. Not sure that's feasible for most people, but the preferred place for care is at home. But the problem is, or a problem with providing care at home, is that it's not a well-controlled environment. And so it's hard to keep track of what's happening to these potent, potentially dangerous medications in the home. And so there's that dilemma. We want to take care of people in their preferred place, but we don't want to put them or their communities at greater risk. So how do we do that safely? Unused medications left in the home increases risk for misuse. And so, like I said, I'm looking to employ a basic intervention to get those medications out of the house. Because I suspect they are just sitting in a medication cabinet, unattended, and it's only a matter of time before some guest comes to the house, a contractor, somebody looks in opens the med cabinet, sees it there, and then it disappears. And I would like to remove that risk if at all possible. My biggest concern is that some kids who haven't really used medications end up experimenting with it and then changes their life forever. So I'm hoping that we can get in there and dispose of some of these medications. Anyway, that's kind of my next step on the horizon. Lessons learned from both the hospice project and the Uplift trial in nursing homes is that the crackdowns on opioid prescribing are creating a lot of hesitancy when we are requesting for needed medications to be prescribed for patients that have serious life-threatening progressive illness. And providers just don't want to put themselves in jeopardy. They don't want their license to be taken away. So they're just being extra cautious. And so it's hard to get good pain management these days. Attention to quality is both a blessing and a curse. Greater oversight by the state and federal government in these settings. I do think it's important, it's needed, but it is also creating tons of bureaucracy, paperwork, and taking away time from patient care. And so if we're going to require these things from these organizations, we also need to support the time and effort it takes to pay attention to those things. Right now, that's not being done. Industry consolidation, both in the hospice study and in the nursing home study, we are seeing tons of small organizations being bought out by large for-profit companies, and how this transition in care is impacting patients and families, that has yet to be seen, but that's going on in both of these healthcare settings. And providers are dealing with burnout, compassion fatigue, compound losses, often due to COVID, staffing shortages, and rapidly shifting policy changes. Those are often needed in order to be nimble and respond to changes in public health crisis, but it's hard to keep up when really you're struggling to provide patient care with a massive caseload on a daily basis. So I feel quite sympathetic for the people that are on the front lines providing the care. I just want to acknowledge a pioneer in the field. This is Florence Wald. She did a sabbatical back in the 60s at St. Christopher's Hospice in the UK. At that time, there were no hospices in the United States, and she stayed there, provided care there, learned their approach to providing end-of-life care, brought that model back to the United States, started the first hospice here, and I don't think she gets as much credit as warranted. And so I'd like to just give kudos to where kudos are due. And with that, I'd just like to say thank you for your time, and got some additional references there. That's a great question. I do think that meticulous pill counts on a regular basis by visiting staff members could be that low-hanging fruit approach that could be encouraged. That takes additional time and effort from direct patient care, but if you could open that medication bottle and look at the number of pills that are there, that could help. One thing that could get in the way of that is we are seeing, there's just an NPR report out the other day, greater instances of counterfeit pills. And so what might be happening in some cases, the actual narcotics are removed from the pill bottles, and counterfeit inert pills are put back in there. So you don't know that the medication has been diverted. So that's one possible limitation to the meticulous pill counts. But I do think that great vigilance on the part of hospice staff when they're out in the home to simply open those medications and count them can be a good way of identifying when medications are going missing or are being actively diverted. Yes.
You mentioned that over 2% of institutions in Washington policy prevented employees from doing. Can you talk about the rationale behind this policy, either on the state level or?
Yeah, so that's a very good question. The federal government, until a couple of years ago, had a policy that many states interpreted to mean that medication became part of the family or the patient's estate as soon as they died. And because of the way that was interpreted, the medication then could not be legally disposed of by hospice employees. That federal law has since been changed, partly because of that. But I think there's a bit of a legacy of, well, we've been, following that policy, and so we're not destroying the medications. There are also some state level policies that are basically, we don't want you touching the medications, let the families do that. And so that might be another source of that. And then you've got your agency level policies, and those are kind of scattered and all over the place. But I do think that federal policy, which treated medications as part of the estate after the death, that really is the reason we see a lot of medications left in the home, unfortunately.
Comment from one of the participants here is Tony Kino. He said, agrees, super interesting topic and a nice talk, lives and facts. Good luck on the next grant application to see if you can give those households one more visit to continue.
Thank you very much, Tony.
All right, I'm sure. I think a little bit of a 10 question, so you can look like it if you want. It has more to do with the policies around who is eligible for hospice care or under what circumstances they're eligible. And so 6 months ago, we were seeking hospice care for my mother-in-law in the state of New York. We were very fortunate to have an in-home caregiver already. And so what we learned is that we could not have both of them at the same time. We had to choose between this ongoing caregiver or hospice, which would provide much less actual care except for the palliative care. So we ended up staying with the usual caregiver. And so I'm curious whether this is a widespread policy, and if so, whether there are things that we consider.
I don't think this is a widespread policy. I wonder, in California, I know that, what state did you?
New York.
New York. In California, in some cases, Medi-Cal will pay for a family caregiver, will reimburse family caregivers for care. And in those cases, I don't think you can have hospice and that family caregiver getting paid. So I don't know if this is a similar situation. Okay, so it's possible that there are competing funding sources, and maybe Medicaid or Medi-Cal or probably not Medicare, but that there's some issue about who's billing for the caregiving time there.
Yeah, just something to keep on the radar, that, it really wasn't choice between an adequate extent of overall care versus any palliative care at all. And so I thought I'd just share that.
Anecdote, well, we asked a couple supplemental questions at the very end of the survey. We basically said, can we ask you 2 more questions? And people said, sure, ask me 2 more questions. And one of the questions that we asked was, what are the most pressing needs that families and patients have? And support for caregivers was, it's hard in qualitative assessment, but that was a very prominent response. And so I do think there's a great need for making sure that family members who are really doing the lion's share of care at the end of life are supported, and that we're not taking away other benefits like hospice. Sure, that requires more funding. And so there are cost issues at play there, but I think it's needed.
Hi, my name is Marcella Binta. We just finished a study and we were doing an intervention with practice family caregivers to increase their self-efficacy when it came specifically to pain, identifying pain and hospice patients. And one of the things that we found was that they felt that this came too late. You know, that pain and all this to be, and then, you know, before they even make a decision about hospital, that could be addressed. The other thing that I noticed, because some of the intervention is many of the caregivers were afraid of giving the pain medication, even when the patient was in pain. And it came out of their own beliefs that the person was going to become addicted. A few times after when the caregiver mentioned that the patient was reluctant to take the medicine. And sometimes patients, caregivers just rationalize why they weren't given that pain medication. We also did an exit interview, and during the exit interview after the patient died, one of the things that they recognized, so I guess, yeah, they were in pain, you know, but they were reluctant to do that.
Yeah, and that is reflected quite a bit in the literature and in my own clinical experience. And it seems that patients and family caregivers are having greater concerns about things like addiction these days. And so, yeah, I think there's a greater need for those kind of interventions to maybe dismantle those concerns or at least address them appropriately so that patients aren't suffering at the end of the day. One issue that I've seen that I think is kind of interesting, I don't really have time to pursue this as a research question, but family caregivers who are vigilant about addressing pain and they're giving good doses, sometimes upon reflection after the death, they feel like, oh, that last dose that I gave caused the death. And so here we have a progressive illness, typically, you know, cancer, pain increases as the cancer grows and spreads. And so more pain management is needed. And, you know, that last dose is given and the caregivers are feeling tremendous guilt, like they caused the death. That's one thing I'd like to try to address. And but anyway, sounds like you're doing some really interesting work. I know that Lynn McPherson, who's a pharmacy guru over at the University of Maryland School of Pharmacy, she is working on a study right now on providing information to hospice family caregivers to address many of those concerns. So it's possible to maybe make a connection for future collaboration.
Well, Bruce is a physician in internal medicine, and she's a part of the care doctor. And what she started was with doing these videos, we do very short videos to where we dramatize, you know, what is happening when someone is in pain and how to recognize I think it's very effective. I mean, I haven't looked at some of the data because I was intervention, so stay away from that. But just based on the responses from the caregivers that during that interview, you know, they really were able to take in a lot from that. So I think a lot can be addressed, you know, through that, but also before, you know, just having and programs, including the medication, you know, to come and take that medication away.
Sure. Yeah, so I guess the question there is, how do we get the information further upstream to these caregivers prior to maybe the terminal phase of the illness so that pain management doesn't get out of control? good question.
I had a couple questions here. So I remember the Maryland Commission on Aging. I remember a couple of years ago, they had a whole presentation to our group about, considerations of changing the policy in Maryland. I know on your slides, sort of rapidly shifting the policy changes. So I'm sitting here not remembering that meeting all that well, knowing the first thing about what the requirements are in Maryland. But I do remember one thing that you had on one of your slides was another family member as one of the main suspected diverters. And I do remember at one part of the discussion, they were talking about some sort of proposal to do, criminal background checks on anyone who lived in the home with the person who was in hospice and receiving opioids as a prescription, and shortening the prescription sort of regulation. If there was anybody with a known criminal record living in the home, and again, I don't know if this was just proposals. I don't know if any of it became law or policies. I wonder if you know what the state is of the situation, what sort of rules there might be specific to Maryland.
So Maryland was one of the states that interpreted the federal law as treating the remaining medications in the home as part of the estate. But when the federal law was revised, Maryland, I think within 2 years, and right before this study, so it was maybe 2017, they changed the state policy so that Maryland hospice providers could dispose of medications. Now, I followed up with some Maryland hospices and asked them about that, and many of them weren't aware that the policy had actually been changed. So they were still using their old practices, basically encouraging family members to dispose of the medications instead of they themselves disposing of the medications. And in terms of criminal background checks, that has not happened. I hope that that sounds like it could really negatively impact home hospice. And so that makes me feel uncomfortable. But in terms of limiting these amounts, I know that most hospices are using 2 weeks or less of medication, so that if medications are diverted, it isn't a ton of pills that are put out on the street or whatever.
I guess another question I had kind of related to this, but you present a lot of great data, but I was wondering if there was any link. You looked at the link between, say, the size of the hospice and whether they had more diversion. But I'm wondering if diversion is also related in any way with whether facilities reported shortages. To what extent are agencies either incentivized or perhaps de-incentivized to even reporting suspected diversion? Just having entered that thinking.
So I did look at correlates with diversion, and that's one thing I didn't look at. I did not look at whether agencies who had reported medication shortages had greater or less levels of suspected or confirmed diversion. But that could be my next article.
Well, I guess my final comment too, as I think, again, I'm sitting here thinking as a methodologist, only one respondent per facility probably. So it would be great if you had enough money to get multiple response per facility. You can do some sort of hierarchical analysis on the kind of reliability of that agency report. But it seems to me that if you're a small organization, it's probably someone higher up, the president or the head clinical person who's actually doing your survey. Whereas if you're a big company, then that gets delegated to somebody else to do that, and that might be a different level of perspective than they have in kind of a big population of the cases they're seeing, as well as their incentives to report or not report.
Sure. Yeah, I do think that the size of the organization, some of these hospices are providing care on a daily basis to 500 patients, or down in Florida, some of them are caring for 1,000 or plus patients. And so how knowledgeable were these informants about what's going on in all of these patient cases. So I do think it was a limitation that we just had one person responding for especially those larger organizations and a lot of patients.
Years ago, when I was doing my master's in social work, I shadowed a social worker, hospice social worker. And one of the visits that we had to do, we had to wait for escort. Yeah, because they were diverting the household, and we had to make sure that the person that was doing that was not there at the time. And they had the drugs, I mean, the medication was brought to the patient very often as to avoid how much was in the home at any time. But we have to wait for escort before we get out of the car and go into the home. So I don't know what they knew or what, what needed to happen. It wasn't too far from here either. But I just remember that, that the medication was the drop-offs, the nurse was very often.
Yeah, in my own work as a hospice social worker, there were a number of family visits that I went out with the hospice nurse because they just wanted some extra support because they were concerned about a similar situation. So we didn't have a formal escort or like a security services that we called. It was just, bring a partner. So you've got more people in the home.
Could make a recommendation for state or federal government for these large corporate structures on how to prevent diversion in these instances. What policy recommendation?
I think two things. One policy recommendation, and this would, I think it's worth the money, but it would take a little more money. But I would allow for one more additional post-death visit by the hospice nurse to dispose of the medications. I think that would go a long way with preventing misuse and diversion, but that's after the death. So that's aftercare. So I guess then the other policy piece would be to come up with some way to encourage pill counts. I said that the quality oversights are a blessing and a curse. And so I don't want to over-regulate hospice. That is a concern. But if we could somehow come up with a policy that encourages pill counts in the home, I'd say those two pieces, money for an additional visit after the death to dispose of the medications, and some way to encourage pill counts in the home. There are a bunch of automated pill dispensers that are out there with apps and all these wonderful things, and the implementation they're kind of expensive, and the implementation has been pretty spotty, so it certainly hasn't been adopted broadly, but they are available. So that could be something that's used more broadly in the future. Hospices right now are using a lot of lock boxes. And so what they'll do is store the medication in a lockbox and give like one family caregiver the key or the combination. And that way you're at least giving one person responsibility. And so that's one thing that's currently being instituted. It's not exactly the automated pill dispenser, which has multiple benefits because you can actually look at like adherence, are people actually taking the medication? So I like your thinking.
So, when the person dies, hospice generally is the one that is called and comes and pronounce the person dead. Is there anything preventing them at the time for having some kind of protocol to just gather all the medication and take it away?
There are a number of things that get in the way of that. These deaths occur like in the middle of the night. There's a lot of chaos. Usually the family is informing relatives about what's going on. The police are sometimes called. Sometimes the police will take the medication. You're dealing with a funeral home, and sometimes if the patient was managing their own medications, which happens in some hospice case, with some hospice patients, it's possible that they die and then you just don't know where they keep it. You can't go through all the house. They've got their own spot where they keep their medication. And so there are a number of things that get in the way of medication being disposed of properly. Of course, there's kind of the next step question of what is the responsible way of disposing of medications? What are the consequences of flushing these potent narcotics down the toilet? FDA says that the environmental impact is negligible, but they don't have any studies to support that. So I think we might, that's another avenue for future research is responsible disposal of medication. Environmentally responsible disposal.
All right, Monique, any more questions and comments from our online friends? John, thank you.
I just want to say thank you for giving me the forum to talk about what I'm passionate about. And I just appreciate your engagement and great questions. So thank you very much.
All right, for today.